Good evening, everyone. My name is Maria Sedeno, and on behalf of Respiplus, it is my pleasure to welcome you to today's webinar. It's another presentation of the Expand Courses online training platform. And today's webinar is called The Role of Pharmacy and Primary Care in Chronic Cough. It will be presented by Dr. Alan Kaplan and Dr. Alan Lowe. We are very pleased to be able to offer this continuing education opportunity made possible by an unrestricted sponsorship from Merck Canada. And a couple of technical aspects that you may already know. If you're connecting to the webinar by phone, please note that your phone line will be muted automatically. If you have any questions, you can use the question and answer section, and we'll try to do the best to answer during the session or at the end. Please note this webinar is being recorded and will be made available for you via YouTube. We have a YouTube channel for the Expand Courses platform, and also on the expandcourses.com, you will get an email. And if you require an attestation of participation for tonight's webinar, this will be emailed to you at the same time as the replay. So just want to give some welcome to our speakers tonight. We're very glad to have two very key people in the field of chronic cough. So Dr. Alan Kaplan is a family physician working in the York region in Ontario, Canada, and the chairperson of the Family Physician Airways Group of Canada, www.fpagc.com. Please go and visit this one. He's the past chairperson of the respiratory section of the College of Family Physicians of Canada and Senate member of the International Primary Care Respiratory Group. He has co-chaired the Community Standards of COPD program for Health Quality Ontario. And in addition, Dr. Kaplan provides his expertise to a number of medical journals across the world. Thank you, Dr. Kaplan. Dr. Alan Lowe is a practicing pharmacist at BioPro Biologics Pharmacy and clinical pharmacist at Fraser Health Authority, with a devoted interest in patient care and interprofessional collaboration. His passion and skills in education is demonstrated through teaching pharmacy students and as a presenter at regional, national, and international conferences. In addition to having authored many publications and studies, Alan is one of the co-authors of a self-management book called The Osteoporosis Book, Bone Health. This is the 4th edition. He is also a co-founding co-editor of Pharmacy Management in Canada and provides patient education videos with healthchoicesfirst.com. He works with a variety of stakeholders in health and strives to develop solutions to close gaps in healthcare so that patients achieve optimal health outcomes and increase quality of life. Thank you, Dr. Allen. So this is really the webinar of the Allens, as you know, as you can see, and I'm going to start to share the screen for tonight's slides. And there we go. So we're good here. I'm just going to pass quickly, but if you want to have a read for disclosing the any financial interest for our speakers. And as I mentioned before, the webinar is supported by an educational grant from Merck. And then the program objectives for tonight is really to discuss and explore the role of pharmacists and primary care professionals regarding the identification and differential diagnosis of chronic cough. But also we want to discuss with you, define some areas to be prioritized within primary care and for pharmacy as well. Pharmacy settings in terms of the provision of resources and tools that we can use to enhance the care for chronic cough patients. And then discussion tonight will take care in 3 parts, where first we're going to talk about the role of pharmacists, then the role of primary care physicians, and then at the end, before we go into a discussion about resources and tools, we're going to have a good discussion between both. So we hope it's going to be very animated. You're going to like the settings. So let's start with that. And I'm going to let Dr. Allen start with the vision for pharmacists.
Thank you, Maria. Thanks for the introduction, and thanks everyone for joining in today. It's interesting that we are talking about cough. It's largely been an area where it's been thought that it's been relatively benign and generally gets ignored. And I'm really happy to say that pharmacists are getting more and more involved. And certainly I've been involved with a network group with chronic cough, and we're just seeing more and more things, as well as many needs that are out there. And so I think it begins just with looking at the cough definitions. And for those of you that haven't really dived into knowing more about cough, there's actually a lot to it. And there are some basic categories that we can just start off with respect to some definitions. So this is kind of an arbitrary definition. We don't have any really scientific basis for it. It just helps us categorize, so it helps our approach, practice, and I guess commonalities across the different disciplines. But essentially, when we talk about acute cough, that's something that is self-limiting, usually infections, that kind of thing, respiratory infections, that last generally less than 3 weeks. So if it's less than 3 weeks duration of cough, we generally expect that we're treating something a little bit more, well, won't call it simple, because some infections aren't simple, but they are limited, and it's not going to continue on. Sometimes there is a subacute phase, or there are some conditions that have a longer phase of symptoms, and this is where we get into the subacute cough, and that's defined as a duration of cough between 3 and 8 weeks. The difficult one that some of you might be seeing, and this is something that you do have to be a little bit more attentive to, and that is this chronic cough that goes on for greater than 8 weeks. So certainly, I'm sure some of you have come across it already, particularly if you're in pharmacy. We are the sources of a lot of cough and cold medications. And particularly with cough, we're seeing patients who are coming in for this cough that they continually ask for different products and kind of cycle through a number of different things. And it might be certainly more than just a simple situation of infection, viral infection, or even allergies. It might be something more serious that needs further workup. So next slide, please, Maria. So the prevalence of chronic cough in pharmacy, I was trying to see if there was some literature on it. And because cough is really just developing, and we don't have a really good science evaluation of it, although there is some data, which we'll talk about a little bit. But I was trying to see if we could get a number of exactly how frequently or how often cough is presenting in the pharmacy. And certainly from a practice point of view, there are certainly people asking us about cough and cold medications frequently. What we don't realize is, are these patients return customers and they've been dealing with this month after month, or is this separate cold infections, or is this the same chronic cough that they repetitively continue to cycle through different medications thinking that there's something that can control it? Or we also have some patients that essentially end up ignoring it and just kind of dealing with it, accepting as a part of growing old, or as part of this is what it's like now, I have this cough all the time. And sometimes they'll have these cough remedies that may decrease it a little bit, but not essentially get rid of it. I think our job in the pharmacy, and we'll talk about this more, is for pharmacists to listen and watch out for these folks that do have a chronic cough, that do have a cough that could be treated and is not appropriately identified, diagnosed, and treated properly. And there's a number of things that might be associated, and we'll kind of get into that a little bit later. But this is where it becomes important to distinguish between the acute, subacute, and the chronic cough situation. So I think part of the real difficulty nowadays is that determining if that cough is a result of another illness or if there is a particular cause to it, because after all, cough is just a symptom. And now with some of the cough that we're unable to control or to eliminate, it might be a condition in and of itself. And also that's something we'd like to talk about more. So as the objectives were listed there, we're going to get into some chronic cough and try to understand it better, but we'd like to get some audience participation as well. So certainly do type in your questions. We'll try and get to there. And we're also going to try to make this more of a discussion so that we can incorporate and develop new things. And that comes to the latter section where we're going to talk about some tools. And I will be inviting and encouraging you to give us some input on what kind of tools are needed out there, because this is a developing area. Next slide, please. So this particular study, the Canadian Longitudinal Study of Aging, is a very interesting one. This is a study where over a period of time, they're regularly going to check in on these 45 plus people in Canada on a regular basis, asking them a number of questions. And so this is why it's longitudinal, and we're going to continue to collect really great information from this. But what's very interesting that's been reported recently is that the overall prevalence at baseline for those people who are reporting a chronic cough seems to be at about 16% on average. So this graph shows you here how many are current smokers that are reporting that they have a cough. Then we've got former smokers, and even the non-smokers. You'll see that there's a relatively, I'll call it a high percentage, that have a cough that's not related to a smoking related situation. But they are having this cough, and it can be as high as like 15%, 16%. So it is out there. That is quite frequent. And I almost guarantee you that these people are coming into the pharmacy on a pretty regular basis. And nowadays, cough has a little bit of a different connotation associated with it. So prior to COVID, of course, a cough is something that occurs and can be annoying, and some people may look over. But nowadays, if you're in a crowded room and you start coughing, certainly there's going to be a lot more eyes on you. The person who's coughing may get more embarrassed, certainly feel more concerned, traumatized, embarrassed. Lots of feelings flow through. And for some, it may even shut them out, and they start to disconnect and not socialize, and those kinds of things become a barrier. So we are entering into a different age where cough has certainly lots of other connotations. And again, it's going to impress upon pharmacists to get involved even more so than before, to try to treat this and mitigate the problems that may continue afterwards. Next slide, please. So here are some guiding principles that were developed by the Canadian Consensus Group. And this was a document that was identified, and Alan Kaplan will talk more about this. But here's some areas where I think pharmacists can come into play and certainly can contribute to the patient's journey through this cough situation, and either resolve it completely if it happens to be a treatable situation where the cough can be eliminated, or whether it be a chronic cough situation where it is more involved and takes more investigations to try to identify exactly what that is. So I think as pharmacists, we can certainly work on the investigation part, and this could be as simple as dealing with the more minor ailments and over-the-counter treatments that we can manage. So this could be things like allergic rhinitis type situations, and it's going to begin with collecting a good history and knowing where the patient stands and what causes it, time frames and things like that. And this is where we're going to get into that tool that will help guide you through some of that process, because a lot of times it's all in the approach. We're in a busy situation with a busy practice, hard to remember exactly, okay, what should I ask this patient and what does it lead me to and what's the next step? And we hope to provide some tools to help you with that. Whether we're able to identify this appropriately or not really will determine whether we should be referring to the primary care physician to do a diagnosis. So if it becomes more than a minor ailment, or if there are certainly alarm symptoms or red flags, we should certainly refer them to a medical assessment and hopefully get that diagnosed. And there's certainly a lot of underdiagnosis of what cough represent. And it's because a lot of patients, of course, will just self-treat it. They don't deem it to be something that's necessary to bring them in to see their primary physician. Sometimes they don't even mention it in many cases, and don't even often bring it up to the pharmacist of the nature of the cough or the cough itself. It's literally asking the pharmacist, what kind of cough remedy. And then it kind of goes straight to that discussion of just getting a cough suppressant. We're also going to see a lot of patients who are in the midst of their cough treatment. And so pharmacists are certainly involved in that as they fill prescriptions, but also there's a chance to ensure that there's good adherence, proper administration of drugs, proper treatment. And we know that cough, when COPD or asthma are not well treated or drugs are not optimized, that can also lead to persisting symptoms of cough and that kind of thing. And as pharmacists, I encourage all of you, if you don't already do it, I certainly will ask every patient that I see to demonstrate their inhaler to me. And until they've shown me kind of 3 times that they can do it well, I don't believe them that people are doing their inhalers appropriately. So in my kind of ad hoc, kind of anecdotal measurements, I think 80% of people who have an inhaler, and there's so many out there, and they keep changing them, that there are so many situations where they do it incorrectly. And some of them just are overt wrong usage, where they're getting almost none of the drug in the appropriate place, and some where it certainly can be optimized. So I encourage everyone to do that demonstration, even if they've been on the inhaler for years. I'd suggest you to evaluate that. And of course, we roll into the monitoring to make sure that the drugs are having its intended effect, checking on the adverse effects and seeing if any adjustments are necessary, and communicating with the physician and patient, educating them if there are any adjustments or changes needed. Next slide, please. So treatment and monitoring therapy is relatively straightforward. We are involved in both the measurement or monitoring of the prescription medications as well as the over-the-counter. One of the ways that we can keep track is certainly through the different medication profile systems we have. Some are better than others, and some provinces have more comprehensive listings. So I know those of you that are from British Columbia, we have access to PharmaNet, which is a comprehensive database of every drug that the patient has filled within a community pharmacy in the province. And we can certainly look back and see what kind of usage of medications they've been cycling through. And then also compiling this in a way where we can communicate well with collaborating healthcare providers to analyze, and in this situation, we're talking about cough, to get a better handle on it. What happens a lot is that there are multiple prescribers as well as pharmacies that might be providing the patient with different medications, different suggestions, and different therapies. Then the patient ends up essentially going all over the place in several cycles and loops that don't end up in any conclusion or a systematic follow-up and systematic treatment. So one of the things that we will be encouraging is more of a systematic approach so that we can deal with this and make it as efficient as possible. Next slide, please. So identifying patients at risk is relatively simple. So I'm going to make it really simplified for the pharmacist in practice who's in a busy practice, is that those that are asking for cough suppressants do an assessment to see if this is a repeat situation, if it is actually viral infections, where people may think they'd be getting subsequent viral infections when it might be just the same cough continuing on. Different types of medications, I think pharmacists are well aware, the ACE inhibitor cough, and even sometimes ARBs. We sometimes believe that ARBs are devoid of any effect on cough, but there are reports, of course, that even ARBs, lower percentage, of course, but also can cause cough. Not as high as the ACE inhibitors, that you'll see reports anywhere from 15 to 20% of patients may report an ACE inhibitor-associated cough. But there are other medications that are sometimes implicated as well. Less commonly, drugs like leflunomide sometimes have been associated, and sitagliptin. And also nowadays, since there's so much attention on cough, when you hear someone coughing and it sounds like the dry hacking cough, and or you see a repeat client who comes back and every time you see them, they're coughing, it's worthwhile to get into that conversation, do an assessment, and ask about that. Next slide. I'm going to pass it over to Dr. Alan Kaplan to talk about the role of the primary care physician after talking about the pharmacist role so far.
Thanks, Alan. And I want to point out that Alan spells his name correctly for any of you other Alans out there, a number of ways you can spell Alan. So listen, thank you. Listen, there's a lot of different healthcare professionals on the call. We've got pharmacists, we've got family doctors, we've got some CREs, and some names, of course, I don't know, but I think that's covering the big group of who's on for right now. So again, as Alan has already said, we want to go through this thought process. First think about the red flags, which I'll touch on. Are we missing something that's going to be life-threatening or dangerous? Can we make a diagnosis? And we include that in both the doctor and the pharmacist, because the pharmacist is often the first person to see people, and they've come up with a pretty good idea what the diagnosis is, but they may not have the ability to do some of the tests that we have to do. So we're going to have to do that in primary care and even secondary care. I'll come back to that. And then, of course, what treatment has been given, what treatment we're thinking about now, and how do we make sure it's working? How do you assess if someone's feeling better? Medicine tends to be very episodic now. So to make sure to book a follow-up appointment, make sure we book a virtual follow-up, make sure things are getting better, and know the times that it expects to work to say something better. Because one of the biggest reasons for a drug, quote, quote, failure is they take it for a week and they're not instantly better and they stop taking the medication. So we have to understand that some medications take a little longer than that to work, and I'll touch on that. Next slide, please, Maria. So in working on a algorithm for this for primary care, and this is available, I'll show you in total afterwards on the FPGC website, the Family Physician Group of Canada website, as Maria talked about. For me, when you've got someone who's coughing, and we're talking about chronic cough, but really any cough to start with, but especially those coughing over 8 weeks, because usually most coughs are going to settle down before 8 weeks, right? And therefore we don't have to worry about that. But those people that continue to have cough for more than 8 weeks, there's something else going on. This is not just a runny nose, although it's one of the causes, but you have to worry about other things. So again, are there red flags, which I'll talk about? Is there a history? And Alan has already talked about some of the medications that can do that. Are they smokers, which of course brings up a whole other list of potential causes? Are there triggers in their environment or their occupation that's doing that? Have they recently traveled? Can be an issue. Examination is worthwhile. It's a big difference if the lungs are completely clear than if you hear crackles or crepitations, which bring up all kinds of things. Crackles can be pneumonia, they can be heart failure, they can be pulmonary fibrosis, interstitial lung disease. That makes a difference. And then that first step that must not be left out is chest x-ray. So I'll say it again, that chest x-ray must not be left out. You say, but they had a chest x-ray already. That's what the patient will say to you. So how long ago was that x-ray? Well, it was a couple of years ago. How long have you been coughing for? I've been coughing for 10 weeks. Well, do you think something might have changed in the last 2 years? So they need another x-ray. And again, I can't tell you how many times that simple first step has found me a result. Sometimes not such a good answer, but at least it gives me an answer, even though they had an x-ray before, because things change. The other things that we think of are the most common causes. So with a normal x-ray, then the most common causes are going to be asthma and gastroesophageal reflux disease. So very straightforward how to assess those things. And, and for asthma, it's doing spirometry. You can get really fancy with something called FeNO, fractionated cell nitric oxide, which is not available in most of the country, but spirometry. Now, I know spirometry has been a bit of a barrier recently with COVID. A lot of spirometry places have been closed. But things are opening up now, and we're able to get this. And again, it's the next step that has to happen to decide if it's asthma, because asthma does not show up on a chest x-ray, does it? We know that. It's a functional problem. Reflux, again, can be a little harder to diagnose firmly. The symptoms are usually there, but of course, you can have reflux that presents with cough. You may get hints with things like dental disease, really bad. I brush my teeth regularly twice a day, I promise. And their spouse, yeah, yes, they do. Or their parent says, yes, I make them, or something like that. But yet they still have really bad dental decay. And that's because the acid literally coming up into their mouth and burning their teeth. There are testing you can do for GERD as well. They can have an endoscopy. They can do an acid measurement test where you put a tube down in your nose into your stomach and you measure the acid. I've yet to have a patient who's really excited by having that test. It's not a very fun test, but sometimes that's what you have to do if you're thinking about asymptomatic GERD. You've got to test it and sort of prove it, or you treat on speculation, which we'll talk about. Right? There's a bunch of other things. The next most common thing is going to be upper airway cough syndrome, or maybe the most common thing, and that is that persistent sinus discharge post-nasal drip that's up in the back of the throat, and then people cough it up and they get a tickle that occurs, when they're snuffing back, and then they get a tickle and then they get a cough. A non-asthmatic eosinophilic bronchitis, which you see also there on the bottom, again, is not an uncommon condition, but it's very difficult. And what that looks like is eosinophilic inflammation of the lung, but no airway obstruction. It just causes cough. The spirometry is normal. Bronchiectasis is a condition you're familiar with, where you get sacs filled up with fluid. Usually that's related to some kind of structural damage, immune problems, and some kind of infection. Next slide, please. So all these things are things we're going to think of. We do the test for it. So Dr. Louis-Philippe Belay, who needs no introduction in Canada, was involved in this program with the Heart and Lung at the University of Laval, and made this big overview. And you can see sort of on the top there, much what Alan talked about. If you can easily identify a cause and treat it, fantastic. If you recognize that they're smokers or they're vaping, or they're using an ACE, well, they should stop doing that thing. Well, easy to tell people to quit smoking. We could talk about that for an hour. I'm not going to, Alan Lowe, don't worry. Maria won't kill our time frame for this. But obviously, smoke cessation is a big topic that all of you deal with on a regular basis. I'm just very thankful that none of you are selling cigarettes anymore, so you don't have that conflict. So congratulations. All right. And then, of course, in the middle, that we have, a bunch of other things to think about. What occupational exposures? So if I see someone who works, they're a baker exposed to flour, or they paint cars. They don't paint cows, they paint cars, and they get isocyanate exposure, which can cause occupational asthma. We're thinking about those kind of things. And then going back to those basics we talked about. And then as you can see that we've highlighted those 4 most common causes to then go looking for, because obviously if there's hoof prints in the distance, it could be a zebra, but still more commonly going to be a horse, and it's almost never going to be a unicorn. So we start with the common things and go from there. So we go to the next slide and we build on that, so you don't have to look at this tiny little writing. And so upper airway cough syndrome, we call that post-nasal drip, allergic rhinitis. A bunch of things can cause it. Usually it's going to be some kind of chronic rhinitis or sinusitis, often allergies. You have a look in the nose, you may get allergy testing. We may do imaging of the CT, like a CT of the sinus. X-rays of the sinus are fairly useless, guys. They'll be positive for lots of people with a cold, and then after the cold, they get better. We're looking at CTs to actually see whether or not there's persistent fluid and a blockage of the osteometal complex, which needs to be drained. So CT, if you're really worried about chronic sinusitis, it's a CT that you need to have done. If you're going to treat that, I really hate the fact that the first thing on this is a decongestant. That's not a good answer. As you all know, nasal decongestants after 3 to 5 days cause dependence and rebound. It's called rhinitis medicanosum. People should not be encouraged to use decongestants because they work, and they work great. And then in a few days, they want to keep using them. And of course, the longer you use it, the worse the problem becomes. So that's not a good idea. But antihistamines, nasal steroids, and nasal antihistamines will work, especially for allergic rhinitis. Nasal just lavage with saline can work. And as a secondary step, you can even move towards leukotriene receptor antagonists, although they don't work as well. But desperate times for different measures, they say. Asthma, we talked about spirometry. As you know, asthma is a variable disease. So sometimes spirometry will be normal. If you're really convinced that's what it is, then you want to do things like a methacholine challenge test or the pheno test I mentioned. And again, the allergies may be an issue there. And in all these things, sometimes we think, well, that's the most likely thing. We're just going to treat this on speculation. So I'll come back to that in a minute. For non-asthmatic eosinophilic bronchitis, it's a very difficult diagnosis in primary care. They test that they often don't have. I have a pheno machine because I do a lot of respiratory consultations. Most people in Canada do not. Most specialists in Canada do not. So it's a great test for me to have and have the availability. It tells me there's eosinophilic inflammation in the lung. We can send people to Hamilton or the 5 or 6 other places in Canada that have a measurement of sputum eosinophils. Great test. You can inhale hypertonic saline till you cough up a piece of your lung. They look at a microscope with lots of eosinophils. Then that tells us it's eosinophilic inflammation. Again, treatment for that would be inhaled steroids for that, and for asthma also inhaled steroids plus a bronchodilator. And for GERD, I talked about the pH monitoring, which people don't want to do. Again, treatment. And here's where the timeline comes in, very important. And I had someone literally today that I spoke to. Well, so my family doctor said that if I take a PPI for a month, it'll tell me whether the cough is from the PPI. Cough is from the reflux. The problem is reflux causes cough in 2 ways. One is it causes some vagal reflex stimulation. And secondly, it actually burns the lung, just like it burns the teeth, as I talked about. So it's going to take more than 1 month to get rid of that burning and let it heal. So we're talking 3 months or even 6 months, and not once a day PPI, but twice a day, full dose PPI. You really got to hit them hard, especially if it's on spec. And people don't like doing that. They're taking a lot of medications. They stop taking it. If they have heartburn, they stop taking it as soon as their heartburn's better, because my heartburn's better. Well, that gets better in a week or even less sometimes within a few days. So we have to recognize the expectation. Inhaled steroids work in the nucleus of the cells. Therefore, they take weeks to start, they start working within the week, but the full effect is 6 to 12 weeks. So again, how long have they treated it for? All this makes a difference. Bronchodilators work fairly quickly, as you know, that's good. But again, we have to think about those expectations. So make sure that you also talk about the expectations as you're making these perhaps empiric treatment decisions, what they should expect, as you're thinking in your mind what the next step will be. So let's move on to the next step, Maria, to talk about that. So if they're not getting better, you go through all those basics first that we just talked about. Alan talked about inhaler technique. If it's going to be inhaler, we're going to talk about, do they take their medication regularly for all the rest of the things? Then you look for less common things, and then you look for some of these things that, we don't see them very often, thankfully, but they're there in your practice. You're going to see them. If you work long enough, you're going to see all of these things. I've seen people present with cough when it's heart failure. Okay, I've seen tuberculosis. I've picked up a number of people with tuberculosis. This is something that happens. Usually going to have an abnormal X-ray, but not necessarily. The CT will give you some hints with upper lobe changes and stuff, but you can have a completely normal X-ray and have pulmonary TB, unfortunately. This refractory cough, neurogenic cough, we're going to touch on in a bit. GI, we talked about. And sometimes it's recurrent aspiration. It's people that don't swallow very well, especially when they're elderly and are commonly aspirating all the time. And I've talked about bronchiectasis. One of the things you don't want to miss is lung cancer. And that's why I said how terribly important it is to get a chest X-ray. And I've seen non-smoking lung cancer is becoming more common. It's up to 15 to almost 20% of people with lung cancer are never smokers. Never smokers. Yes, you can blame it on radon, do radon detectors in your home. That's all very important. But actually, that usually isn't the answer. These people, they just get cancer. It's unlucky. It's unlucky. It's a genetic mutation that happens. All this stuff is very real. If you don't do the X-ray, you're not going to see it. And of course, you can even miss an early cancer on an X-ray, as you all know. If you really believe that's the situation, you may want to go into a CT scan. And occasionally, I will send people for bronchoscopy to look for an endobrachial tumor that might be causing a cough. All these things can happen. I've touched on interstitial lung disease. And okay, there's some medications that can cause interstitial lung disease. So think about that as well as the pharmacist, as the doctor. Are they on a drug that can cause that? Amiodarone is one, methotrexate's another, macrodantin is another. These are common ones that can actually do that. Outside the drugs that just have cough as a side effect, these are medications that cause interstitial fibrosis as a side effect. So think about that. And of course, then there's idiopathic pulmonary fibrosis, a whole other condition. And how do you diagnose that? You listen to their lungs and hear crackles, and you look at their fingers and see if they have clubbing. Right? And that gives you a good idea about that. Let's move on to the next slide, please, again, Maria. So these are all things that go through your head. So that's why I touch on the red flags there, right? So the history is on the left, the red flags, right? If you're coughing up blood, that's a problem. If you're a smoker with a new cough and a change, really, sure, it could be COPD. So you do the spirometry and see, but you make sure it's not a cancer first. I'm very worried about that group, right? If they're very short of breath, cough and shortness of breath has a whole different differential. Cough and loss of voice has a different differential. Cough with systemic symptoms, fever, weight loss. You're thinking about that TB story we talked about. If you're getting swollen, gaining a lot of weight suddenly, you're thinking about heart failure or renal failure, things like that. So you see how many things can then come up with fluid overload. Trouble swallowing, recurrent vomiting, recurrent real pneumonia. Are they aspirating? Do they have an immune deficiency? You see, the list goes on and on and on, doesn't it? And I'm not trying to overwhelm you with the list. I'm just trying to get you to think of what are those red flags that make you say, hey, I could be missing something really important. I'm not going to fool around with this one. Here, this person doesn't get a trial of therapy of a PPI because I think it might be their stomach, or give them a nasal spray. No, they require investigation. So again, your history, cough duration. We're talking about over 8 weeks here. What started it? I'm seeing someone right now. It started after a surgery. That's when it started. So that could either be a red flag, or it could actually be a red herring. And I'm still working out for this particular lady which one it is, but you have to be important. Is it productive? Is it purulent? Like coughing up purulent sputum, that's different than if they're not coughing up anything. If they're coughing stuff up, that's a different differential than that's a dry cough. Okay. We talked about travel and the TB risk factors. We talked about the other issues and the other risk factors. We talked about whether it's smoking. And of course, don't forget there's other things people smoke. It's all kinds of things people smoke. So we have to worry about all those things that they do that, and what medications. We've touched on that. So I've given you a lot to think about there. But again, if you remember the red flags here, you're not going to miss anything terribly important as you then go through this time. You may get frustrated, people. And of course, I think that's one of the biggest problems here is people get frustrated. And one of the issues that happens with frustrated people is they no longer come back to see you because they're frustrated. You've tried A and B and C and they're still coughing. They say, well, you clearly don't know what you're doing because I'm still coughing. And they get frustrated. They look for help somewhere else. They go to the naturopath. We've all had patients that do that, looking for a magic answer. They go to the pharmacist, as Alan talked about, and try a whole bunch of stuff over the counter because they're frustrated, and they lose faith in us as healthcare practitioners because we're not solving it. Which brings me to the next slide and the other end of my algorithm, which says, please make sure, thanks, Maria, please make sure that you're supporting the patient while you're going through this. So one of the things that's resonated for me, and patients have said it back to me, and they said, you saying that made all the difference in the world, is, you know what, I don't know what this is yet. I have a bunch of steps I've got to go through, which may include some referrals to a bunch of different people to try to figure out what's doing this, because there's no obvious answer. But what I do promise is we're going to get to the bottom of this. We're going to find a solution to help you. And you've got me with you through this entire journey. And we're going to keep track of it together, because they're frustrated and they're sad and they get upset and they get mood issues. And they cough so much that they're incontinent of their urine. They got to wear pads. Of course, that sells more pads in the pharmacy, Alan, but I don't think that's what anybody really wants. I mean, what we really want to do is make people feel better. And there's a whole list of different other studies that can be done. The most common will be a CT here, but you can see there's a whole bunch of things that could happen there. So if we want to move on to the next slide, I just want to reinforce again that our basics here are chest X-ray and spirometry. I think a CBC is always a good idea. You get all kinds of hints of all kinds of other things. CT is something that I move to fairly frequently because it tells me all kinds of structural things that happen in the lung. So I've got a lady that I'm seeing right now with chronic cough. Her spirometry showed 25% reversibility. She was a smoker. I did a CT scan of her lungs anyhow, which was interesting because triple therapy for their asthma medications did not make her cough better. Now her CT scan shows a bunch of nodules and atelectasis and a few other interesting things that now I've got to follow because there's something else going on. So these are things we sort of have to figure out what's going on. And I'm still not sure what's the matter with her. So again, please do those basics. Okay, I know there's a lot of pressure on you in practice to refer, Okay. Pharmacists, please remind the patient they need to have a chest x-ray if they haven't had one. Don't be shy about that. Bottom up pressure to the doctor to remind what's important is a good thing. They may get a little bit upset, but it will push them to do the right thing. And spirometry availability is a problem, so we have to recognize that as well. So I wanted to move on from that to our other group of people here, which are the respiratory therapy, the CREs, and whether you're a pharmacist or RT. Next slide, please, Maria, to talk about what do you need as a group, and I guess clearly it's going to depend on where you're working and who you're working with. And I know that CREs are working in all kinds of settings that does that. As a pharmacist CRA, everything that Alan said is already applicable. Plus, often a little bit more about things like spirometry and stuff like that, so you can talk about that more. Many of you are already seeing patients with a particular disease. So they've got this disease, they're labeled already with this disease, and often you substantiated the diagnosis with that, but they're still coughing. So now you got to think, wait a minute, they're still coughing and they've got asthma. So why is that? Is it the asthma is not treated? So we reassess the asthma, we do the spirometry, we look at inflammation, and they're still coughing. Because some asthmatics will have a refractory cough. We have to approach that a little bit differently. It may be the asthma is being treated properly, or it may be all the common things like they're not taking their medication regularly. So we call that about RCC, which is a refractory chronic cough. We have a diagnosis, but it hasn't got better. And we'll compare that to a UCC, which is an unexplained chronic cough, which means we've done everything we can think of. They've seen every specialist in the world, and nobody can come up with an answer. And we have a frustrated group of patients there. So the next slide will then talk about our approach as a CRE. And I'd be interested to hear back your comments afterwards. I know the CRE is in the audience, but again, it's really the same thing. We're all doing the same job. We just have some different tools. So we do a history and physical. We review the medications that they're taking now and have been taking. They make sure they've had the basic investigations at least, right? And you ask about those symptoms. Do you have a stuffy nose? Do you have a stiff back? Do you have a tickle in your throat? Are you coughing stuff up? Do you have heartburn? Does your voice change? The teeth issues, all things we talked about. Identify those red flags, which then require an urgent referral or urgent discussion with the physician that you have a relationship with. So if you have a really good day, you can even come up with a diagnosis yourself and then step that up to the doc you're working with and say, here, I've got a patient with chronic cough who's got asthma, who actually seems to also have GERD as well. Maybe that's why they're not getting better. And you see how that works together. So with all that, I'll pass back to Alan Lowe because I've been talking too long.
Not at all. That's a great update. And it just shows how busy you are and how much work that you have to do. And I think what we wanted to get into with this particular webinar is kind of discuss how we can work together. It is hard enough already. And I'm sure the audience has seen that there are a lot of differential diagnosis to deal with. And not only is there a lot of differentials, but to get to the point where you can even rule out one diagnosis to the other requires a lot of input from the patient as well as from the other healthcare providers to optimize and make sure the other things were done right and done appropriately. So I think that although, we are talking kind of the physician pharmacist kind of view here, certainly the CREs are involved, and you can see where the allied health fits in, like the pharmacist, in helping not only to triage, but to help the patient navigate a little bit and to help steer this whole process to make our healthcare system more efficient. Because right now, if patients were left to it on their own, they're going to be going all over the place, differentials running all over, and it's hard enough across Canada to get visits with physicians. And if that's the case, and oftentimes if they're going into walk-in clinics, they're seeing a different physician each time. And with communications as they are, certainly better among physicians in the same office. But once we get into pharmacists and physicians who don't have a common platform to share information, then we get into CREs and where spirometry results are available and all the rest of it. We're just so disconnected that we have to find a way to work together better. And we're going to use this case to try to illustrate that. So let me just kind of present this, and we're going to use this more of a discussion and kind of back and forth, and certainly want to entertain your questions at this point as well. So think about a 58-year-old female here who has had cough for the past 2 years, comes to the pharmacy describing the cough that's been getting worse over the last couple of months. The medication's pretty straightforward in this patient is that they only have a diagnosis of hypertension, currently taking amlodipine 10 milligrams once daily, and from a COVID vaccine status has received their primary series as well as the one booster, so that's the third shot with Moderna. And we have a few questions that we can kind of ask. How should the pharmacist manage this patient's concern? When should the pharmacist refer the patient? And how would the physician manage this patient? So let me just begin with some of the steps taken to manage this particular patient as they present to us. Now, this particular patient actually was, if you can go back to the previous slide, sorry, thanks, Maria, that they did actually were started on ACE inhibitor. And the thing is that ACE inhibitors are the most commonly used antihypertensive out there today. So it is very high use in volume. And of course, everybody will gravitate to that. As soon as you hear a cough, see an ACE inhibitor, first thing you do is, we're going to change it. Let's try something else and see if it resolves the problem. And in this particular case, switching to amlodipine, same thing. Patient describes that there has been no changes with respect to the cough. The hypertension, blood pressure results are still nicely controlled. So patient is doing fine from that point of view. So now it's going into that history taking of what do we do next, and gathering, I guess, all the quality and background with regards to that cough. And, this will be summarized a little bit on the checklist and tool that we're going to suggest to you that will begin to circulate and help you go through this process. But it's going to start off with categorizing this. Is this an acute cough? Is this subacute? Is this chronic? And with a 2-year history, and we see that it's not intermittent. So it's not like they had it for a few months, it's gone away for months, and then it comes back. But this is consistent. We want to get a date of onset from the patient as best possible. Maybe get the characteristics of the cough. So what kind of is it productive sputum? Is it a dry cough, hacking cough? Is it causing other symptoms such as vomiting? Is it causing incontinence? Is it causing pain? Certainly look for any of the red flags, any blood in the sputum, anything that's being coughed up. We might even ask them about their environmental exposures, whether the hot air, cold air changes anything, foods that they eat, drinks that they have, whether it's associated with speaking, irritants that they associate with, other symptoms, chest pain, changes in speech, I think is also an important one. And of course, if they're a smoker or not, and past or former smoker. Not that we can do too much about the former smoker, but it might lead us down a different path with respect to maybe a development of COPD, worries about lung cancer. Not that you have to have been a smoker to develop lung cancer, but as Dr. Kaplan has mentioned, always a concern and always something there to continue to watch for. Any other respiratory diagnoses that maybe haven't been picked up yet. So certainly this patient is at an age where other respiratory conditions can develop when we're talking about COPD. Asthma still can occur later on in life, less common, but certainly can be. And also to rule out any infections that might be going on. But with a 2-year history, we're probably not talking about an acute infection. So other things, I'm going to ask Dr. Kaplan that you would hope the pharmacist would kind of go through after we go through our history. We will try to, I guess, if we identify anything, we try to work through the simple things if there's a GERD kind of issue. But we're talking 2 years. So what's your view?
So, what have they done about their cough already? What have they tried already for it? Because I'm sure in 2 years, they've tried a lot of medications. Have they talked to their doctor? Have they had any tests or consults that, have said, no, it's not that? Have they seen a gastroenterologist for their stomach or ear, nose, and throat for their nose, or a respirologist and had breathing tests, or any of those things? Have they been done already? I also like asking about the onset of the cough. When did it start? And most people don't know. They don't remember after 2 years, but some people say, I know it happened after that trip I took to so-and-so, right? Or something was really specific about it. And don't forget the constitutional symptoms. Have you lost weight that was unexpected? Have you been having fevers back and forth? Have, things like that make you think about other things. Where does she come from? Has she traveled somewhere? So all the stuff has been captured already. We've mentioned it, so I don't want to repeat it too much. But the factor here is we need to have an organized approach to it. Now, I gave you a whole list of things, which I realize after I'm saying it, that could be quite mind-boggling. But the point about having the algorithms that we're going to show you is they actually let you go step by step to think about those things, rule them in and rule them out. And then you actually have a really nice approach to it, rather than just taking that whole big soup of things that I spoke to and said, you got to figure out that whole bunch of things. No, if we approach it step by step, you will come to the answer.
Thanks for that. And I think that's where we get into where the pharmacist role, if we're talking pharmacists, is that medication usage. And I think that is what certainly we're best at. And we have the knowledge, background, detail, and access to the information to really capture a detailed history with regards to this. And I'm going to encourage everyone, if you're asking these questions, make sure they get documented and then get shared. And this is key, because this is going to be important for everyone who's assessing this patient to see what kinds of medications that they've gone through, what doses that they've used, because this is the other thing. It's already been mentioned that, when using PPIs, that the appropriate effective dose needs to be used. And sometimes the titration process isn't gone through. There's one dose used, the patient gives up because they've tried it, doesn't think it works, and they've only been on the initial or starting dose. And if that's been identified, of course, we can arrive at a conclusion of maybe reattempting those drugs or with a different one, but to be more effective or use a higher dose against it, particularly if we're talking about patients who might have larger or higher body weight and may need higher doses for the effect and that kind of thing. So again, and in the end, we're going to show you a bit of a tool that will help you, but it's pretty straightforward. We're looking at documenting the drug, the dose that was used, the date started, the date that it stopped, and then just documenting the response from that, and in a systematic diarized fashion. So patients aren't exactly greatest when we get into the recall. So if you do have a prescription database, ideally it's a provincial one, but if not, pulling it from your own databases, it'll capture mainly the prescription medications. But I'm going to suggest to you that there is worthwhile, and you'll actually create loyalty and a better patient base and return clients if you also capture and enter their non-prescription medications. I think pharmacists more and more are beginning to get into the habit of entering those into the system, and the systems are making it easier now. You can program them in, you can capture OTC items into your system so that they come up, they're in a pull down menu and searchable. You may have to enter it the first time, but once it's there you go. And now you can start capturing it, and you're going to also let this patient know that you know about them. You've got capture of their OTCs that they used 2 years ago. And that's going to become important as we try to work through these differentials. So let's say this patient was describing some things that sounded like GERD. They're having some indigestion after they eat food. You're suspecting that maybe this cough might have association with that. We're going to ask further questions about the use of H2 antagonists, potentially antacids, use of PPIs. Start looking to the prescription database to see what kind of use of H2 antagonists and PPIs have been used. And then if we collect up that information and see that we have either optimized what we can do over the counter, it might be the next step to then refer to the family physician with additional information provided that says, we've tried, or I've talked to this patient, captured this history. These are the doses they've tried. This is what we've tried recently with dates, stop dates, and responses. This will give the family physician a much better basis to begin to do the diagnosis, to do the other workup and investigations without having to do the trial and error of acid lowering treatments as a test. And certainly, as Dr. Kaplan has mentioned, nobody wants to get esophageal pH testing, not fun. So they'd much rather go through a trial of anti-secretory, antacid type medication to see where that goes. Any other comments you want to add, Alan?
Yeah. So many people think, well, I have GERD, but I've taken an antacid and that didn't cure my cough, or I've taken an H2 blocker, didn't cure my cough. Unfortunately, those are probably not acid suppressing enough to solve the problem. And they usually don't take it long enough to make a difference anyhow, but certainly they're not enough. So we're lucky enough to have PPIs, so let's use the right medication for it. Every condition that we talked about has red flags as well. So even when you're talking about if it's GERD, also the red flags for that. So do they have trouble swallowing? Do they feel food sticking? Are they recurrent vomiting? Those would all be red flags for things other than just routine reflux disease. So all those things are stuff that we need to communicate because they also change the urgency of the appointment. So if you're saying go see your doctor, I say, please go see your doctor because you're having heartburn and you're having trouble swallowing, things are sticking. To me, that's an urgent endoscopy because I want to rule out an esophageal cancer or a stricture. That's urgent. Very different than I've been coughing for 2 years. The pharmacist thinks I might have heartburn. That's it's an entirely different discussion when it comes to making an appointment. So again, highlighting those concerns you have at the same time. You don't have to write them all down because the doctor will be able to figure out what you're thinking of. But if they don't know about it, they can't actually act upon it.
And I'll just pick up on that point about writing something down. I've gotten into the habit of always making a little note for the patient to take with them to their doctor. If I'm going to be suggesting that they go visit with their doctor, their recall and what they retain from what we've told them is certainly very poor. They may not use the right words. They may not be saying the right things. And when a physician can receive, and I'll confirm this with Alan, that if you get a note from a pharmacist that's descriptive and some more details of what we think it is and what we've worked through, that probably helps you out. So I'm going to assume that that's the case, and I've certainly heard some good feedback. Have you had many pharmacists send you notes like that?
We have notes going back and forth. I never ignore a pharmacist note, but I must say I don't always get responses back from the notes I send to pharmacists. So I'll just leave that out there hanging.
Really, I'm surprised with that, because usually we're saying that we're not getting responses the other way. I thought we'd be a lot more attentive in responding back. But I guess there's certainly improvements on both sides, and everybody's going to have different kinds of practices in how they communicate. We're still lacking platforms. We are not doing well with our electronic health record to be able to share information. Hopefully it's going to get better, but for now, unfortunately, we're still stuck with facts and notes being carried by patients. But on a baseline level, it is working. It's better than not, but I've got to say that there's certainly more solutions that we can go to.
So if we want to touch on that right now, because we're going to talk about that later, but let's touch on this now, is how we can actually communicate, because as Alan said, communication is the important thing here. We really need to actually figure that out. So I know a lot of pharmacies have doctor lines, doctor specific lines, and that's great, because calling through in a general line can really be agonizing. And similarly, I would hope that there's private lines that we can actually provide the pharmacist, for an important thing. So again, but it has to not be abused. It has to be for an important thing, not every single prescription renewal that you need because the person's yelling at you right there. Otherwise, that's not going to work. Do we have a dedicated fax line where we actually look at this regularly? Unfortunately, and again, I'm not disparaging anyone, but I've literally sent prescriptions into a pharmacy by fax in the morning, and then I get a phone call from the patient saying that they don't have it yet. And I say, well, have them look at the bottom of the fax pile, which they haven't had a chance to get through yet. Right. And I understand we're all busy. Everyone's busy. Calling doesn't work because, very well, because nobody likes to be on hold for half an hour in any way. And the last thing is, well, you can use this as a medication reconciliation, which is fantastic, right? And not all the provinces have that, but unfortunately, when I get a medication reconciliation, it's 4 or 5 pages, and the recommendation is at the bottom of the last page in small type. Well, that needs to be at the top of the first page, so I can read that recommendation and then support it with all the things that you add. So let's make sure we communicate better is really the important thing here, because we both have something to say to each other that's important for the patient.
Great point. Great point. And actually, I'm going to urge us on to continue, because I know we're getting close to time, and I see that there are a couple of questions, but there's just a few more things that we want to go through. So I'm going to go through this very quickly, and I think that you've kind of picked up on the fact that there's getting to be more and more of these coughs that are chronic, and there is no diagnosis, there is no actual identification, and we end up calling it unexplained chronic cough. Now, that was a term that wasn't used too often before. But before we even get there, we have to get through refractory sometimes to know that we have tried everything we can. And have we actually tried everything we can is always the question. But there are these neurogenic causes of cough that are being identified now, that there are many CNS targets as well as airway targets, different modulators and receptors that are there. And of course, new medications being produced that are targeted at these particular sites. Now, this is brand new science, and some of it is still just postulated and potentials, because it's certainly still not well understood, getting better and better. I'm going to pass it over to you, Alan, if you had additional comments, and just wanted to keep it quick just to let people know that this is going on.
Yeah. So understanding that new stuff is coming, it's exciting. We have medications that work for these unexplained chronic coughs once everything else has been ruled out. The way I think about this is people who have neuropathic pain. So we all deal with patients with neuropathic pain, that there's not a structural reason you can see there, yet the nervous system is driving it. And the nervous system does drive most things. Certainly with pain comes from the brain, as you know. So if you think about it that way, where it's sort of a neuropathic cough, and we've called it neurogenic cough, we've called it hypersensitivity coughs, we've called many things. Now we call it UCC. But the key thing here is the nerves are involved. And we use products right now, like things like Lyrica, gabapentin, and things like that, but there's new medications coming. And of course, that's going to require a certain degree of expertise to get into those medicines, but you're going to start seeing people given medications like that for cough. So you don't look at them cross-eyed and say, well, why are they giving you Lyrica for your cough? I don't understand. That makes no sense. Even that innocent kind of a comment can actually go a long way to breaking things up. So understand that this is coming. And I think that's probably not much we need to talk about that right now, Al. So if we move on to the next slide, We're very quickly going to the next slide. We're going to talk about a few questionnaires and tools and where you can get them. So this is that primary care algorithm to cough that I talked about. I'm not going to go into any more detail. We've talked about it. Before. You can get this on the website, fpagc.com, in our tools section. You don't have to be a doctor to go to our website. We welcome everybody. We've got lots of pharmacists that join us regularly, as well as CREs. So please do. This is one example of a primary care approach. The next slide. So as part of an article that I wrote with Dr. Imran Sadia, who's a respirologist at the Firestone, who came from the UK, who's one of our leading Canadian cough experts, along with Louis-Philippe Boulay and Stephen Field, you see there as well. We created some other algorithms as well. So this is the primary care algorithm as part of this article. The nice thing about this, it's not really different much from the others, but it talks about some of the treatments because I didn't put treatment in the initial algorithm. And then in the next slide, it's going to get into, I think went backwards, there we go. In the next slide, just to give you an idea of what happens when patients get referred to a cough center, to a specialist. So we can take this in primary care as far as we can go. Often they need other things. They may need a bronchoscopy. They may need a challenge test. They may need the pH probe we talked about. They may need a scope, and so on. They may need endoscopy for their nose to have a look inside. Laryngoscopies. These are things that most of us in primary care cannot do, and therefore you need the appropriate specialist to figure that stuff out, right? And then from there, they use things like questionnaires. I'll touch on one in a moment. And one of the two big tools they have, one of them is a speech pathologist. And if your area is blessed to have a speech pathologist with an interest in cough, they can teach all kinds of behavioral things that can make a difference even to these people that are suffering. And while it does not cure the disease, it helps them. And I've talked about the neuromodulatory trials. We talked about Lyrica gabapentin, amitriptyline. I was one of the first drugs that got used for neuropathic cough with an improvement compared to narcotic cough syrup. It was a very impressive trial. It's an old trial. It's 25 years old already. We can talk about opioids. Be cautious about that. Be very cautious about opioid cough syrups, right? Again, this just is dangerous on so many different levels. So a ridiculously quick story. I was involved as an expert for someone. A doctor gave somebody a course of azithromycin and a small bottle of narcotic cough syrup in university for studying. The next morning, they found him dead. I was asked to give an opinion. I said, well, I need the autopsy first. The autopsy showed that he drank the entire bottle of cough syrup at one point. He had an acute overdose. Not on purpose. He just wanted to stop coughing, right? Nobody did anything wrong here. Just the young man made a bad decision. So, but low-dose morphine can be a trial. It's being used because opioid centers also involved in cough. So these are some things that happen. Obviously, it's not something you're going to do in the office every day. It's not the first recommendation by any means, but you can see how that might be used. And then we've got these new medications coming. A couple are closer to happening. So we move on to the next slide, and then the one after that, Maria. So one of the tools I use in the clinic is a measurement of efficacy. So clinicians are getting used to using these tools all the time. We're using a PHQ-9 for depression, a GAD-7 for anxiety, a BPI for pain, and here's an ACQ for asthma. This is the Leicester Cough Questionnaire. It's a bunch of questions over the last couple of weeks about both the symptoms, how it's making them feel, how concerned you are, how much it's affecting your life. And the nice thing about that is as you treat something, especially when you're not sure, using a neuromodulator trial, you really have to have something to measure to see it's getting better. So you may hear the LCQ being used and a score in the LCQ back in the report, and it gives you an idea of how much improvement they've had to see if it's there. So a very nice tool to get an idea of how that's working. Next slide. And again, just for information, for the fun of it, there's all kinds of technology coming. So we have now things that count coughs. All right, so it's pretty cool. It may be your iPhone that's sort of in the background, always listening. Yes, your iPhone is always on in the background, counting your steps and listening to you. And that's why it asks you questions about things you just talked about. Very scary, but it can count your coughs. And the next slide talks about things like artificial intelligence, where they've actually created artificial intelligence tools based on the type of cough, the data you can analyze, the triggers that are available. Next slide. And then with all that, they're created into these algorithms that actually have cough acquisition devices. Some of them are in smartphones, some of them are in spirometers and microphones and all the stuff that you can see there. I'm certainly not going to go into detail for that. There's no point. But what it does tell us is that the future is going to be interesting for cough. And as Alan said at the beginning, this is a new and developing technology. So I want to pass it back to Alan Lowe for the next slide to talk about some things we can do in the pharmacy and work on together. You're muted, Al.
So with that respect, we hope to be creating a number of different management and assessment tools to help the pharmacist, as well as allied health as well. And we want to aim at a few specific objectives. That is to help the pharmacist systematically capture history, because it's always helpful to have a checklist rather than to just do it from memory. Help steer that pharmacist's assessment to take the next step. And you can see how complicated it is as we're going through all the different cost scenarios, the causes and the treatments, and to also compile this information in an efficient way so it can be transferred to the next healthcare professional as they kind of take the baton and move with the patient through the rest of the journey. Next slide, please. So this is a draft, a little bit small, but let me just walk you through very quickly. It's got the demographics. We talked about capturing the history of the patient and the background. And this is really to highlight some of the key things that are associated with cough, to generate that thought process, to think about whether it's asthma, whether it's COPD, whether you need to call it smoking cessation and put them onto smoking cessation therapy. And I think across the nation nowadays, we have smoking cessation therapies that are covered, that are part of the, I guess, reimbursable services that pharmacists can do, and certainly would encourage you to take advantage of that and help the patient. Capturing different kinds of symptoms, particularly the alarm symptoms. So the red flags are called out there, giving you a table to capture the medications, the responses, the dates of starting and stopping. Also coming up with kind of next steps. And I think this is particularly important to document what those next steps we want are. And then the patient can take that with them, patient can refer back to it, and also it becomes a part of their data and history that they can kind of maintain and keep. Unfortunately, the pharmacies aren't particularly good at that still. All of our pharmacy management systems, we can scan in documents, but they aren't built to be a monitoring system to follow patients through. And I know that in the Q&A, there was a question about, will a pharmacist accept and want to see the care plan from a CRE? I'd say absolutely yes. We want to see it. We want to use that to make our time more efficient as we work with the patient, as they come in for their refills and get their medications, et cetera. But the problems that we run into is that the pharmacist has no good way to go back to it. It's even worse than the paper file. It's not that we have paper patient files kind of put away all over the place. We scan everything into a system, and it requires a person to look at the scan and pull something up, and capture notes on comment fields is kind of as good as it gets. And it's unfortunate that the pharmacy management systems haven't caught up to our clinical care. I hope that that's coming soon, and I continue to encourage different software vendors to do that. But it's those kind of things that will help us along. But I'm going to encourage all healthcare providers, as Alan Kaplan has mentioned, is that we need to exchange information. We need to find ways to communicate. Talk with your healthcare colleague, how they best communicate and how they'd like to get it. Not everybody wants a fax. Not everybody wants an email. I certainly also text communicate with some of the physicians that I work with. And on the back of this tool, we've also got some definitions and some basic information, as well as some resources. I know that at the end of this, you're going to get an evaluation to give us some input. I'd like you to also include what kind of tools or frequently asked questions that we should prepare answers to that you'll have at your fingertips. So rather than you having to go look up, search, and find things in this very difficult area because it's developing, that we can come up with these tools and create documents that are shareable, that are useful to multiple people, multiple healthcare providers, and can be communicated both to the patient and to other healthcare providers. So I encourage you to give us that kind of input.
So just let me add a couple points to that and just answer the questions that have come up. Ellen, you asked about action plans specifically. And listen, that's a great thing. It's important that action plan does get, obviously the patient has it, gets sent to the clinician involved. That's often an issue because many people don't have family doctors anymore. They may just have the specialist that involves them in the program that you're working at. So that's an issue. So I think having the patient go over that with the pharmacist is important, because not everybody knows how to activate or even utilize an action plan. So that's going to be important that they actually use that in the future in their management. So the patient's going to come up with an action plan and say, well, I'm feeling like this, I need to step up to the next step. Let's do this together. So it's a good idea for them to review that with the pharmacist as well as their clinician. In terms of that frequent asked question document, we're not quite finished on it. Al and I and the Respiplus team has been working, trying to get it all perfect for tonight. It's not quite there yet, so we have a little bit of work to do. But this is certainly something that we are planning to then get out into circulation and want it out there for us to have, both as a way for you to keep track in the pharmacy, as a way for us to do in the practice, frankly, is a nice thing for us to go back to, but also as that communication tool between. And the last question was what management of cough with long COVID? So that's just a really easy question to answer in just a couple of minutes. We're already over time. But how about I make it really easy? And let's make cough really easy. Alan said it's really, really difficult. You know what? Nothing in medicine is difficult as long as you have an approach to it. Hey, there's a real truism. So we've given you the approach and we've given you the tools to go back and have a look at to do that approach. So have your approach to it. And long COVID is no different. So cough after COVID would be the first description, because long COVID is now its own word and its own meaning. What's not? What is the reason for that cough? And it's the same tests. So spirometry, do they have asthma? I can't tell you how many asthmatics have newly shown up post-COVID. Okay, a CT scan. A CT scan will tell me whether we have interstitial change in your lung related to fibrosis from COVID pneumonia. You don't get it very often from Omicron unless you're unlucky enough to get Omicron pneumonia. So do they have persistent fibrosis? If they don't have persistent fibrosis, it's got nothing to do with the COVID. Right? Do they have persistent postnasal drip because of a viral infection? Do they have a pulmonary embolism where the risk of a PE lasts for a year, 51 weeks to be exact, a higher risk after COVID, right? So you can see the first thing you're doing is doing the workup. And only after you've done all those things are you maybe left with a very small number of people that have cough post-COVID. But I can tell you a secret, by the time you've done all those tests and given them a few treatments, they're probably going to be better. Okay, remember, we haven't had long COVID for years and years yet for most people. The ones that had long COVID after the first Alpha Delta, they had fibrotic lung disease, and even they are mostly getting better with their shortness of breath and their cough. So the good news is most will get better from the COVID for the chest symptoms, be it shortness of breath as well as cough. So Don, I hope that gives you an idea of how to approach that long COVID. Long COVID itself is not a diagnosis. It's another way of long COVID cough will be another way of calling it UCC or unexplained chronic cough because we don't have an answer. You've done the same workup though, Don. So I hope that makes some sense and gives you an answer. And with that, I think we've asked our questions. Thank you. I'll just say thank you now for speaking, and I'll pass it on to Alan and Maria to close up.
Thank you. I don't think I have much more to add other than I'll just add one more caveat to that long COVID is there's too many associations with all sorts of new symptoms being associated with long COVID. I'd suggest that we discourage, I guess, that linking and do the systematic approach and properly work it up so that we don't get tied into something like that and perpetuate it. So with that, I'd also thank the audience for tuning in and learning more about chronic cough. Thank you.
That's so great, actually, because people are asking about the tool, as Dr. Alan Kaplan mentioned, it's still being working. But tonight, as you exit the webinar, you will have to answer a very short survey. Please, you have the chance to give us any feedback about the tool, what's missing, what would you like to see, and we can work on that and have a better document that we'll present and will be widely available later on. In the meantime, there are two websites, chronic-cough.com, which is also, there's a multitude of tools and information there, as well as the chronic-lung-diseases.com. We have many pages, but there is one section on chronic cough, which I recommend. There is a report that was done around the chronic cough patient journey, which includes really from the perspective of the patient, the perspective of the healthcare professional, all the algorithms that you have seen tonight. So this is work that was done for almost over a year for a fantastic panel of experts, including Dr. Kaplan and Lowe here tonight. So with that, I just want to thank everyone for staying late with us tonight. And thank you to Dr. Alan Kaplan and Dr. Alan Lowe. It was a fantastic webinar. Thank you, everyone.
Bye, guys. From the two Allens, we say thanks for coming.
Yes, the Allen show is over for tonight. Thank you.
Thank you very much.
Good night all.
Good night.